going to have talk on very interesting, I think, case presentation with regard to pericardial effusion. Dr. Ahmed Nourelbagi, he's a cardiology fellow in Medina Cardiac Centers, who will going to give us, I think, an excellent talk on how to deal with complications.
Yes, my name Ahmed Nourelbagi, Abdallah Eltyeib, adult cardiology fellowship in Saudi Arabia, Medina Cardiac Center. We present 40 years old male patient on background history of chronic kidney disease, status post renal transplant 9 years ago. He is known case of type 1 diabetes since age of 10, hypertensive for last 10 years. Patient referred to our hospital service from periphery hospital, presented there with cardiac tamponade. They tried to do urgent pericardiocentesis there. Unfortunately, during the procedure, the patient developed ventricular tachycardia and became shocked. They did for him resuscitation and transferred to our service for further workup. When he presented, patient was ill, pale, in severe chest pain. Blood pressure was 180/90, pulse rate 92, sinus rhythm. He was afebrile with puffy face with generalized body swelling. Chest was clear, cardiovascular examination, muffled heart sound, and there is no murmur. Abdomen distended, and there is surgical scar of renal transplant. No organomegaly, and there is also lower limb edema. His lab show hemoglobin of 6.6, white blood cell was 10,000, platelet was 180 with ASR 10. Creatinine was 465, potassium was 5.8, with BH show metabolic acidosis. Transthoracic echo done, which show massive pericardial effusion with pericardial hematoma, measuring about 8 centimeter by 2 centimeters in thickness. This is his chest X-ray, which show cardiomegaly with clear lung fields. This is his echo. As you can see here, there is hematoma around the posterolateral wall of the left ventricle. There is massive pericardial effusion. Is it clear, Abdulrhman?
Is this before tapping or after tapping?
Yeah, this is before tapping. You see the hematoma, Dr. Abubaker?
Yes, but the
or we need to run again. Sorry, it's not so clear.
Oh yeah, now it's clear.
Yeah. Dr. Jameil, your comment?
It's a large hematoma. This is Abubaker again.
Can we play again, please, for audience?
I think if you go back to the apical 4-chamber view, it's probably the best view.
Okay.
And just leave it at that, because the other views really underestimate this effusion.
Yeah. There is also, we can see concentric LVH, normal LV function, no significant valvular lesion. short axis view.
خليتي طبعا يا أحمد.
Go ahead, Abdulrhman. Go ahead.
لا I guess you can let it run just to see there is collapse. You can not frame by frame, run it just.
You can freeze here to show for chamber view.
Just we want to see the signs for tamponade. Whether we have RA collapse, RB collapse, something like that. You can run it just to let it. Okay.
Just go back. Go back once, please. Once again. I think it's very difficult, Abdulrhman, to make an assessment because the clips are not running smoothly. They're almost like frame by frame clips.
No feature of actually of cardiac tamponade in this image, but it's massive pericardial effusion with hematoma measuring.
How far is that center where they did the initial attempt?
About 300 kilo from Medina Cardiac Center.
Wow, quite far. Okay.
Yeah, Yambo.
Okay. I'm not sure if there's any actual evidence of tamponade, and I'm not sure if I would call this as very large effusion. Yes, there's some effusion. Yes, there is some hematoma.
Because when presented there to periphery hospital, he was in tamponade, and they tried to do urgent pericardiocentesis, and during the procedure, I think there is some injury of RV or so the patient during the procedure, when they remove about 400 ml, develop VTAC and shock. So we suspect RV injury, so they refer urgently.
So they have actually managed to get about 400 mils out.
Yeah.
Okay. And did they describe what they got out? Did they say?
Yeah. After that, after the patient develop VTAC and become shocked, they repeat bedside echo, which shows that the size of pericardial effusion is increasing.
Increased?
Yeah, increased after this puncture. So it was serous after that. When we do pericardiocentesis in our center, it's stained with blood.
Yeah, it seems that, Abubaker?
Yes.
What I understood, the patient has, I think, renal failure, and he has large pericardial effusion. I'm not sure whether he had tamponade or not there, but I mean, they attempted the pericardiocentesis. Do you know what approach they use, Ahmed?
Subcostal. Subexvoid,
okay. So they we will come to that one later on, and Abubaker maybe will help in that. Anyway, so after they did pericardiocentesis, they got complicated by cardiac arrest, VTAC cardiac arrest, I think, or VF cardiac arrest. They resuscitated him and sent him to the higher center for further management. This is what I understood.
Was he in shock, or was it just a VT?
Yeah, just for a while during.
So
the
he wasn't in
of,
arrest. So he did not actually.
No.
Okay.
No.
So his blood pressure dropped, and he had VT.
Yeah. And there is a drop in hemoglobin. When he arrived to our center, hemoglobin 6.6, normocytic normochromic anemia with high creatinine. We discovered that he developed chronic rejection because he already did renal transplant 9 years ago.
But this 6.6, Ahmed, from what was the
baseline?
This renal failure patient, they have anemia.
Yeah, we don't know the baseline, but after he arrived, 6.6 is his.
Still is very low, I think.
Yeah.
So that hematoma or bleeding into the pericardium can explain, some hemoglobin.
Yeah. So our plan of treatment to give him supportive management for pain and we give him 3 units of blood, and we did for him pericardiocentesis under fluoroscopy and echo guided. We offer for him hemodialysis and we treat the pericardial hematoma conservatively and other supportive measures of management.
Just before you did the pericardiocentesis, can you tell us more about his hemodynamics at the time?
When he presented, he was pale and he had uncontrolled blood pressure 180/90. We used to give him Pericardial Effusion. Otherwise, he's stable, heart rate 92, sinus rhythm.
So my next question is, then what are the indications of pericardiocentesis at that point?
Yeah, because the pericardial effusion was massive, but no tamponade.
Okay.
Yeah.
Yes, Abubakar. If you notice, if you go back to the slide, a few slides back, Ahmed, to the physical examination, the blood pressure. If there is, I mean, like, okay, go back. Okay, you see the blood pressure, Abubakar, I think 180/90. Okay, and this leads, lead us to false negative and false positive diagnosis of cardiac tamponade. So the one of the false negative, if you have a very high blood pressure like this one, or if you have severe pulmonary hypertension, or if you have severe AI, ASD, patient on positive, ventilator, all this will give us the false negative because intracardiac pressure is so high to be compressed by the intrapericardial pressure, because there is like a balance between the intrapericardial and intracardiac. Okay, and I guess the thing preventing him from going into tamponade at this point is the shooting of the blood pressure, high blood pressure. So intracardiac pressure is very high. I think so. This is one factor. Although we don't have, the full, the echo loops, and because of streaming, as you said, we cannot see, clearly the signs to look for the signs of the tamponade. And obviously the IVC, from what we see, is dilated and not collapsible. So I guess the pressure is high into the pericardial also. And on the other hand, the false positive, if you have hypertension or shock, something like that, we call it low pressure tamponade. Okay, and also to add to the false negative, if it is localized or post-surgical, for example, the adhesion, something like that, like LA tamponade or LV tamponade, you can have isolated like LA tamponade in certain cases. So I guess if the absence of signs of tamponade, echo signs of tamponade in this patient could be explained partially or partly by the high blood pressure. I think so. Abubakar.
Abdulrhman, so I got interrupted by my little queen here. Sorry. So my question would be here. Okay, this is likely to be chronic pericardial effusion, not an acute pericardial effusion. Exactly. And secondly, to proceed for pericardiocentesis, we would have to have some sort of convincing evidence that this is pending tamponade or peri-tamponade or tamponading, either hemodynamically or echocardiographically, which I don't think neither exists.
Agree, especially that Abubakar, if we suspect perforation, because if you suspect perforation, which might sealed by that hematoma, when you do pericardiocentesis, you might open it up and you will end up with, like open, like Masura Fatha. Okay. I think I think, and you might encounter in cath lab, Abubakar, when you, for example, not you personally, of course, but I mean, you might have seen when perforation of the coronaries or something like that, a patient bled into the pericardia. It becomes always, I mean, debate whether to do pericardiocentesis or to send the patient for surgery. But we will come to that one when we discuss the management of, I mean, the complication of pericardiocentesis. And your input in this one will be very, I mean, valuable.
Thank you.
very much.
Thank you, Abdulrhman. Please proceed, Ahmed. Sorry for.
Okay. Regarding few causes of pericardial effusion, it could be due to malignancy, uremia, as in our case, tuberculosis in developing countries, hypothyroidism, connective tissue disease like systemic lupus erythematosus, other like post-surgery, EBS study, or castration. Pericardiocentesis was first described in 1653 by Relonos. It was used to do sternotomy, then to do drainage, which was not convincing and associated with high mortality. Ultrasound guided technique in 1970 has become the diagnostic and management of most hemodynamically significant pericardial effusion. The procedure can be performed safely in an outpatient setting for carefully selected stable patient to relieve symptoms of pericardial tamponade. Echocardiography guided pericardiocentesis has success rate of more than 95% with relative little risk. The morbidity rate is about 1 to 3%, and mortality rate from injury caused by the procedure is less than 1%. Complication of pericardiocentesis, cardiac perforation that lead to iatrogenic tamponade, hemodynamic dearrangement, pericardial decompression, which lead to pulmonary edema, iatrogenic injury to surrounding structure like diaphragm, stomach, liver, hemorrhagic peritonitis or hemoperitoneum in case of subxiphoid approach, and cardiac arrhythmia and vasovagal reaction as in our patient. And pneumopericardium, this can occur due to suction or due to leakage from the pericardial centesis set. We have to know few about the cardiac tamponade sign and symptom. What's called big triad consists of hypotension and distended neck vein, small and silent heart. You have to know few about echo sign of cardiac tamponade like right atrial diastolic collapse, which is more sensitive, and RV diastolic collapse, which is more specific, and IV plethora with inferior vena cava dilatation and non-collapsing. Also echo Doppler of cardiac tamponades, which involve drop in A velocity by more than 40% in tricuspid valve during expiration and more than 25% in mitral valve during expiration. So take home message, pericardiocentesis is simple and life-saving procedure, but serious complication can occur as an outpatient. Uremia, one of the commonest cause of cardiac tamponade, and pericardiocentesis is class 1 indication for cardiac tamponade. Thank you very much.
Excellent, thank you.
Thank you very much, Dr. Ahmed. This was an excellent presentation, and I think really the take-home message from your talk here, I think for myself and for my colleague, junior registrar, cardiology registrar, I think when we see patient with pericardial effusion, or from the beginning, I think for any unstable patient with breathlessness, low blood pressure, tachycardia, I think in most of the case from clinical assessment, I think before the imaging, you will be able to make your judgment in terms of clinical sign of pericardial effusion. So I think the take-home message here in this case, I think careful assessment, as just Dr. Abubaker mentioned that in terms of sign and symptom of tamponade. And I think the second thing is also when we do pericardiocentesis for our patient. I know your case, I think mainly with regard perforation, query perforation. However, we haven't had CT scan to confirm that. But I think you nicely mentioned that there is other complications like arrhythmia, like pericardial decompression, and also like hemodynamic decompensation after the pericardiocentesis. So I think now I would like to ask the panel if they want to make any comment or if they have any question to Dr. Ahmed.
Yes.
Okay. Yeah, go ahead, Dr. Abdulrhman.
Lazim.
Yeah, please go ahead.
Yes, yeah. Thank you very much, Ahmed, for excellent presentation and nice case. First of all, we talked already about the echo signs and false positive and false negative. This is important and we have to keep in mind. Then regarding the approaches for, I'm not an invasive, guy, but we used to do pericardiocentesis in Shab Teaching Hospital many years ago. Maybe Hind will remember that. I don't know if he don't remember. I don't know. Anyway, but we used to do it blindly. At that time, there was no echo, there was no fluoroscopy. And the only approach we have is subcostal because this is the safest, I think, one, and we can do it in emergency always. But here in our hospital, their practice, they tend to do apical approach more than others. Apical mainly approach, especially Dr. Fayaz Khan Abubaker knows him very well, his friend. He used to do apical approach. And from what I see from him, he's very careful and he's very good really in this pericardiocentesis because we do echo guided for them. So first of all, he is doing it always echo guided. Okay, number one. Number two, he used to go initially with small needle, micro needle, and he inject bubbles, okay, to make sure he is in the pericardial space, air bubble, just air bubbles. After that, he will take out the small needle. He knows the space already by echo and by the needle. And he will go by the big one and then by the wire and big tails. And even after that one also, he will confirm the presence of this one. I attended with him one time, only one complication. The patient has malignancy and she had large pericardial effusion. She doesn't have apical because I think she has C breast or something like that. She doesn't have apical window. She doesn't have subcostal window. She cannot lie flat. She was very sick. The only window available for him was parasternal. Okay, and this is for me for the first time to see this parasternal approach. He approached the pericardium through the fifth intercostal space close to the sternum, and was successful that one. And but later on the patient died 48 hours after from her metastasis and the primary illness. And of course, as I said, subcostal, we do it in emergency cases. And again, it depends, the approach depends on the location, the size, the situation, the condition of the patient, the circumstances, the expertise of the operator. But the subcostal, it is, I think it is safest approach. And if you use this, echo guide and bubble and micro needle in the beginning, we will end up with a safe, I think, pericardiocentesis. Regarding the indication for pericardiocentesis and the urgency when to do pericardiocentesis, in 2014, the European, I think they produced and published guidelines or strategy for pericardiocentesis, and they make like scores, points from 3 categories. For example, first of all, from the clinical point of view, if the patient, for example, has malignancy, this will have a score of 2. If he has renal failure, a score of 1.5, something like that, okay? Then radiological and the clinical presentation, like if the patient has cardiomegaly by chest X-ray, the patient has tachycardia, the patient had orthopnea, all this will score it. And then at the end, the imaging, the echo, RV diastolic collapse, RAO collapse, respiratory variation, IVC plethora. So just they will call. If the sum of the total score more than 6, there is indication for urgent pericardiocentesis. Of course, we conditions like cardiac tamponade complicating aortic dissection, for example, or free wall rupture, or perforation, causing, I mean, like the patient already on coagulopathy or something like that. This all an indication for cardiac surgery, regardless of the signs of tamponade. Thank you.
Great. Thanks very much, Abdulrhman.
Thank you very much, Dr. Jameil.
Thank you very much. Just before you go, Dr. Abubakar, just I have a question for you.
Yes.
I know Dr. Abdulrhman, he is imaging cardiologist. He given his opinion with regard to how to treat and how to diagnose this and how to assess patient with pericardial effusion. Excellent talk. So in case if this patient now had hemodynamically unstable with massive pericardial effusion with clinically an imaging finding of tamponade, what's your initial approach? Would you call for surgeon or would you try again pericardiocentesis?
Thanks, Abdulazim, and thanks, Ahmed, for the elegant talk. And thanks, Abdulrahman, for the excellent comments, as usual. With regard to choosing the approach or choosing the next step, it all depends on, first of all, the patient's stability and the size of the effusion and the potential access and potential complications. In this particular situation, I probably have time to talk to the surgeon and consider a much more kind of semi-urgent, not emergent surgical window to give the patient just long-term benefit and just more controlled procedure and much safer, because the patient is hemodynamically stable. There's good perfusion. The patient is not in shock at the moment. Things are okay. What has happened probably in the previous center, they may have injured the RV or they may have caused some sort of iatrogenic damage and the patient bled. And clearly the hematoma probably helped to stabilize the patient to get to this point, which is a blessing. If the needle goes into the ventricle, sometimes the needle just, I think the ventricle just contracts and basically seal off that small puncture. The problem really arises by putting the sheath in. Once you put in the sheath or the pigtail into the ventricle, it's a no return point. The other thing is when we do even a safe pericardial pericardiocentesis, the wire that you pass around in the pericardial space will touch the external wall of the ventricles, and that itself can cause ventricular tachycardias and ectopics and so on, which can be hemodynamically compromising, especially with someone with that degree of left ventricular hypertrophy, which is very severe. So the fact that he had VT and he had a transient shock may have been a combination of the wire in the pericardial space. The wire and the needle must have touched the ventricle, the right ventricle in particular, because it's very anterior structure. Then it sealed itself. Here, in this particular case, I would consult with a surgeon. I will keep the patient and wait for more definitive, much more safer, non-emergent pericardial window. Now, in a pericardial tamponade, in an acute pericardial tamponade, or in patients who have unexplained pericardial effusion, which is extremely large, that you would think it is safer to go percutaneously in a stable situation, you can certainly do it percutaneously rather than surgically. And there you also need diagnostic in addition to therapeutic effect of the pericardiocentesis. So in those situations, then you're pretty confident that you can get it in whichever suitable angles. There are certain steps I will discuss in a little bit, but I just want to hear from you, Abdulazim and Ahmed and Abdulrhman, Jameil, if you have any comments.
Yes, really, in this case, Abubaker,
Yes.
the hematoma usually will end with adhesions and fibrosis, and this patient might end up with constrictive pericarditis later on, or effusive constrictive. So I don't know, I would agree with you to consult the cardiac surgeon to do pericardial window and to evacuate the hematoma. But to leave it like this, I think it is quite large, and it might end up with either effusive constrictive or chronic constrictive later on.
Right. Ahmed, any comment?
Yeah, my comment in this case, first after we receive call from there, we are afraid, we call already the surgeon, we activate the cath lab because we suspect, massive injury to RV. But alhamdulillah, after the patient arrived, he was stable, just he's complaining of chest pain. Otherwise, a little bit high blood pressure controlled with anti-G infusion. So we consult surgeon, so advice for conservative management. Only we did pericardioccentesis.
Excellent, excellent. Abdulazim, do you want me to talk in any particular aspect?
Thank you, Dr. Abubaker. I think you really covered the main things regarding this case. I mean, the main intervention, when you intervene for this kind of patient, I mean, it's the message clearly here. If the patient hemodynamically stable, I think you got time to prepare and to call for surgeon. And I think otherwise, I think the situation is different. So I'm not sure, Dr. Hind, would you like to add anything? Sorry, unmute your microphone, Dr. Hind, please.
First of all, I would like to thank Dr. Ahmed for the nice
Dr. Ahmed,
for the nice presentation, and also Dr. Abdulrhman, Jameil, and Dr. Abubaker for all their comments, valuable comments. Actually, everything has been covered. I enjoyed the talk and all the knowledge that we've learned today.
Thank you.
And I don't really have a question.
Thanks. Yeah, I think it's overall, I think it's very, very rich case. I think there's a lot of discussion around this case, and it's always pericardial effusion and cardiac tamponade is life-threatening condition, and pericardiocentesis life-saving procedure, and it does carry complications. And I think the take-home message here, I think we need to be very careful when we perform the procedure, and we need to observe patient for complication, as Dr. Ahmed mentioned. And I think now we reached the conclusion to this webinar today. And I really would like to thank all our speakers today, or our faculty. I would like to start by Dr. Abdulrahman Jameil, Dr. Abubaker Khalil, and Dr. Abdallah Eltyeib, Dr. Muhannad Agrid, and Dr. Ahmed Nourelbagi, Dr. Muhammad Abdelgadir, Dr. Hind Al-Zain, and hopefully we will see you shortly with new guidelines presentation. So our next webinar is hopefully going to be around non-STEMI 2020 European Society guidelines, and we will cover the TAMPONADE talk, which is ACS update on antiplatelet therapy, antithrombotic therapy, and also we're hoping to cover the new guideline for atrial fibrillations. So thank you very much, and we really appreciate your time.
Thank you very much.
Thank you.
Thank you very much, Abdulazim, for the invitation and for the arrangement of this nice webinar. And really, your efforts are highly appreciated, and you're doing very well, inshallah. Thank you very much.
Dr. Ahmed Nourelbagi, mashallah, well done. والله أنت في بلد مبروك. May Allah bless you.
يا دكتور أبو بكر خليل، شكرا لك كثير.
الله يسلمك.
Thank you.